What are you doing, Tina?
What are you doing, Jenny?
We are two women living our best lives in the Black Hills of South Dakota, sharing our stories, laughs, and projects happening in the garage.
Whether you're looking for a bit of joy, a spark of creativity, or just a comforting voice, you can find it here. Unicorn!
Welcome to another episode of the Unicorn Projects, and we have a special guest with us today, Dr. May.
Yes.
Dr. May, Jennifer May. And Jennifer and I went to high school together. And her mother, Nancy May, was my 9th grade English teacher. So
oh my gosh. I didn't know that part.
All
yeah,
true.
we read Romeo and Juliet. Mm-hmm.
You just know everyone, Jenny.
Well,
Jenny's
all the
mom
best
taught at the
people.
high school also.
Yeah, my mom taught at the high school also with Jennifer's mom.
Yeah.
And then Tina,
Yes.
you know.
I know Jennifer,
Jennifer.
and her husband from my days at Arrowhead, so
Yes.
I've known them for a little
Long
more
time.
than a decade. Yeah, 10, 12 years.
My
And
husband's a golfer.
Steve is very much a golfer, and he is just, he was always one of my favorites. They're very easygoing.
Very easygoing guy.
They are self-contained. They are low maintenance, if not
This
no
is true.
maintenance.
This is true.
And I just, plus he's just a nice human.
Super
so.
nice guy.
Yeah.
I agree.
Well, we had some requests from listeners to have somebody on to talk about autoimmune. We've been very open about Tina's Crohn's disease journey. And, you know, after Tina's near-death experience in July, and all of the quirky ways that Tina's body reacts to things because she has Crohn's, we just had a lot of interest and comments to have somebody on. And so Jennifer May is a rheumatologist. And if you're like a lot of people, you're probably like, what's a rheumatologist? And so I'm going to ask you to explain what a rheumatologist is because I will do a bad job.
I guess what the explanation I give is, so obviously I'm a physician and I trained in internal medicine. That's like an adult doctor, right? And then if you want to subspecialize, so if you go to a cardiologist or a pulmonologist or anybody that specializes in a specific organ, they had to be an internist first. So then you train. And I picked rheumatology, which is, I would say, musculoskeletal. The things that people think of are rheumatoid arthritis and lupus and that kind of thing. But we've kind of evolved, because science has improved significantly and immune system education has improved significantly. So to managing autoimmune diseases, not like every one of them. I had a patient ask me recently, can't you take care of all of them? No, we cannot. But like the ones that affect your musculoskeletal system, so usually associated with joint swelling, but like lupus, for example, affects multiple organs. So sometimes we're dealing with lung issues, and so we kind of end up taking care of a lot of different organ systems, collaborating with other people. If you're, for example, Crohn's, like people with Crohn's can get joint swelling, and so then I'm working with the GI person about picking the right medicine that maybe helps cover all these symptoms. If they're getting, like we call it extra articular. So if you have rheumatoid and you're getting symptoms that are not just joints, rashes, lung involvement, whatever. So it can be a lot of other things, but we kind of work in that realm of identifying if your immune system is overactive and are there ways we can target that to drive that down so that you have less symptoms.
So do you team up with other doctors as well
All the
with
time.
patients?
In rheumatology, for me anyway, it requires a lot of collaboration. And it kind of just depends. I mean, sometimes I can just do it by myself. But, like, maybe I need the kidney doctor or the nephrologist to help you with your lupus nephritis. Like, it's more, your kidney function's getting to a point where now it's more complicated. I need their support. For fibrosis of the lungs, we definitely need the pulmonologist to tell us, is it worse? I take care of a lot of people with eye disease, right? So I need the ophthalmologist to tell me if their eyes are active or not active, right? And then I direct the therapy. So, we do collaborate quite a bit. Once we get people under control, then sometimes they don't need to visit those people as often. But lots of times it's a group effort.
It seems like it takes extensive knowledge to be a rheumatologist with the autoimmune.
Because your cross collaboration is with so many other
It is.
departments and
It's definitely
specialties.
chronic disease.
Yes.
So it's chronic disease management, which is hard.
Yeah. Oh, I know.
And not something that we that we do well.
Yeah.
Right? I mean, like, everybody's very siloed.
Yes.
This is our culture of being very siloed. And so to do that collaboration really takes extra time. Right? You don't do it you can't do it then. You have your full busy day. You have to clean out all your lab stuff. You have to turn all your patient phone calls. And then you got to find time to go call somebody. Right? So it's not very well built into our current system, like, of quality.
Sure. Do you feel like there could be a kind of multi-pronged question? Do you feel like the patient can help drive some of that collaboration?
Yes and no. So on the one hand, yes, they can, and they do. Patients say, will you please call my gastroenterologist? Will you please call you people need to talk. I mean, they will,
Say
when they
things like
don't
that.
feel
Yes.
like they are getting where they need to go, they will share that. But they also sometimes don't know that we should be collaborating.
Sure.
So, for example, I had a patient who has a lung problem. She has rheumatoid, she has lung problem, and she's had COVID a couple times. And it's kind of confusing, like, what's driving her lung problem. And we've tried some different therapies. And so we sent her to the pulmonologist, sent her to Mayo. And long story short, she ended up seeing this rheumatologist at Mayo who's really specialized in lung disease. She's fantastic. And I think the patient's like, well, I think you take good care of me. And I don't know. And I go, this is how she's going to help us. And this is why I need you to stay connected with her for now. I can reach out to her. Like, I can do the work. But every now and again, I might need to go, is this still the right way to go?
Right.
Because this person is living and breathing the current guidelines that are changing. Things change so quickly. And I'm like just the grunt out in the middle of South Dakota or whatever, in the middle of nowhere. I'm not reading all those guidelines every day. I'm not, I'm just not. So I need someone who's like, the best thing to do in this unique, complicated person is this.
Right.
And so she's like, sometimes they just, because they fthen like they're seeing the same person.
Yes.
And they have to travel. And around here, people have to travel sometimes for collaboration. And then, healthcare's so expensive. I think people really expect a lot out of their
Providers,
dollar, right? Like, if I have to travel and go there, I expect to be cured.
You're right.
At the other
almost.
end, right?
Yeah,
There's a lot of
exactly.
expectation. If they go and they kind of get, yep, they're doing great, they're like, why do I have to come back here?
Right.
Right? So sometimes you have to explain how it's helpful.
To me, in my own journey with Crohn's, things move so rapidly with how I'm feeling from day to day. And there can be new symptoms that impact my body physically that I've never had an issue with before that suddenly arise. And for someone like me, I play it off. I'm like, oh, it's because, for example, I have had this situation lately, in particularly with both hands, across my mid-knuckle in both hands, where I will wake up in the middle of the night and I cannot make a fist. Literally can't make a fist. They hurt so bad. And this has been going on probably since the situation in July. And I have just kind of taken it to be, well, my body's still recovering. I've been slowly incorporating manual labor and physical activity back into my day-to-day because of the recovery. And that's what I relate it to. And I think most people we don't want to be a burden.
We explain it away.
Yes.
Yeah.
And we don't want to bring it up. We don't want to be a burden. But the more I think about it, well, what if that's a new side effect of my condition? And I should probably go see or talk to somebody about that. I feel like with autoimmune disease,
I think what you're really describing is managing expectations.
Yes.
Right? So that is a huge part of what we do, because people watch a television show and everyone's cured by the end of the television show, right?
Right.
The
House.
mystery is solved, everything's taken care of.
Yeah.
And we do so many things well. Really, like there's diseases that you died of that we
Right.
treat very well. You have minimal symptoms and you live a long and healthy life.
Yes.
They're diseases people have never heard of, right? So you don't know it till you have it, right? And so, but there's some things that we just don't do as well. And so people have this expectation that, well, if we can do that for rheumatoid, if my friend with rheumatoid can come see you and have almost no symptoms, why can't you fix my other problems, right? And other things maybe not as good at, like degenerative arthritis or osteoarthritis, which is not autoimmune,
No.
right? But very uncomfortable, and we're just not as good at it. And people will feel like, well, this should be better. We should be,
yeah.
and so,
Right.
or they come in, I have rheumatoid. You're telling me I have rheumatoid. I'll start these meds, and like, they expect in 8 to 10 weeks to be better, right? And so, and sometimes with our diseases, you're very sick by the time we finally figure out what you have. And I'll tell people it might be a year or 2 before you start to feel like yourself. You have to start helping
Managing
people understand what to expect.
Yes.
So they're not quite like, because for some people, not everyone's different, right? And everyone's disease is different,
Right.
right?
Yes.
And so it's not like it's a cookie cutter, everyone has the same experience. Some people are more self-aware and anxious, and all these symptoms are going to make them really nervous.
Right.
And other people, they just, maybe like,
Yeah.
I'll just, and then they'll bring it up to their
Take
next
some
appointment, and
Tylenol.
we're like, oh, you should have mentioned that. But otherwise, like, there are other people that are like, come in, with everything, because they're just so worried that everything is a thing, right? Because they don't know what to expect. So they don't want to miss it. They don't want to be late. They don't want to have another bad outcome or bad
episode or-
experience.
yeah.
So it's all about, like, that's each person. Every person's different. So you got to figure out that person, and you've got to help them
That's gotta
manage
be
that.
hard.
So you have to see people often.
Yes.
In the early stages, you have to see them often. Some people don't want this. Some people are like, this is crazy. I don't want to come that much. And you're like, well, till we get you dialed in, we have to see you often. And we have lots of, now that you can just type your doctor.
Oh, yes, in the My Chart.
So much.
Yeah.
It's a lot. I mean, and I don't know. I mean, to be honest, I would say it's going to kill outpatient medicine, because it's great, right?
hard, though.
But that is a whole day of responding
Yes.
to messages that is not built into, and you don't get compensated for any of that, right? So you have to find a way to get that done. And it's great because you can quickly get back to somebody.
one-off question.
Yeah. And that's good, and you want to be helpful, and people are usually respectful. We always try to say, like, it's not, we're not texting each other. But that's a whole nother piece. But it's like, we got to find a way to get these people to be reassured. Like you said,
Yeah.
my fingers, I can't make fists. Should I be worried about that? If you could just type that, they'd be like, and they're like, that happens. Keep an eye on it. We'll see you in 3 weeks. We'll talk about it at your appointment. Then you'd be like, okay, I'm reassured that
Yeah.
I'm
Like-
not leaving something unchecked. And by the time I see you, it's too
It's
late.
too late.
And my fingers are gonna fall off.
Right.
Yeah.
Which is kind of how people's brains go.
They do.
Yeah.
They
Because when
can.
you don't understand, like we take for granted, I think, as physicians and people in healthcare, how much we know and how much people don't know
That's
about their
such
bodies.
a good statement.
Yeah. And I think that's especially true with autoimmune diseases, which to me still have, I mean, we've come a long way with stigma around autoimmune, but I still think there is like a vein of this like misunderstanding about autoimmune diseases all in your head, especially like with fibromyalgia and some things like that.
Yeah, you don't see it. You don't.
And that's a good. So what I would say is, like fibromyalgia is not an autoimmune disease.
Oh.
right. So
I didn't even know that.
What is it?
This is 100% my day. I do this all day.
I love this. This is great. I had no idea.
So autoimmunity, right? I mean, I'm sure you all know this, but I'll just, for clarification, is when your body decides it doesn't like something about you, right? So your immune system should know you, and it should know what isn't you. And something happens where it starts to react to your own healthy tissue and create some kind of damage that results in a very visible, palpable, seeable problem. You have ulcers up and down your colon. You have rashes on your skin like psoriasis. Your thyroid goes kaput because you have thyroid antibodies. You have inflammation of your eyeballs. There is we can see, touch, and feel. Your joints swell. They don't just hurt, right? There's swelling, there's range of motion loss, there's erosions or damage to the joints on x-rays. Like, we can see, touch, and feel. Your labs are abnormal. Inflammation markers will glow up. There might be certain targets that we can see. You can have, of course, it's rheumatology, so we say, you never say never. You can have rip-roaring rheumatoid arthritis and have normal labs. You can, but the exam is not normal. So fibromyalgia is what we would call, and I learned this term recently from somebody else, but a primary pain problem, meaning it's not from a disease and it's not from like a trauma. It is coming from your central nervous system. So it is basically people with fibromyalgia generally, and again, there's a spectrum where this description falls. You could call it widespread chronic pain. I mean, there's a million different terms for it, but it's people who hurt kind of all over, muscles and joints, right? And I could examine the joints, and I always say, like, if I sat in a room, didn't talk to you, examine you, and left, I would never know you have 9 out of 10 pain.
Wow.
Right? It's not visible, right? I always say it's gray symptoms, fatigue, you can't measure it. You know, it's just these, like a brain fog,
Kind of a
like you can't
nebulous
measure
sort
it,
of-
right? You can't,
Yeah.
and their labs are normal, and they hurt all over. So it's front, back, left, right, top, bottom, 24 hours a day, 7 days a week. It's not better with activity, or nothing helps it. Like, so whereas inflammatory joint pain, you feel better when you get going.
Yeah.
People will like, once I get going, I'm fine, and then I stop and I stove up. Mechanical pain, you know, you get up, you're a little stiff. Like, we all get stiff as we age.
Yeah.
You get up, you know, you're 10 minutes, you walk out of it, right?
Yeah.
Or you get out of the car after driving and you hobble your way to the restroom, and then you're like, finally, you're like, okay, I'm good now, right? That's not, I won't say it's normal, but that's not a disease, right?
Yeah.
Then you go for a walk, and you, by the 3rd mile, you're like, oh, this knee's killing me. I got to stop and rest. That's mechanical pain, right?
Okay.
So that's, and then there's neuropathic pain, or this nervy pain, which is this pain that does not make any sense. It is, can be disabling. It's very real, but it's more a way in which your brain interprets signals. And I think it can, like we've learned from COVID, long COVID, which is basically a form of fibromyalgia, right? It's that same mechanism. We've had post-viral syndromes for years. People get chronic fatigue syndrome, which now they've changed that name to myalgic encephalitis with chronic fatigue. To kind of give it
I've
more
never heard
credit.
that.
I haven't either.
It's called what it now?
What is it
Myalgic
called?
encephalitis / chronic fatigue syndrome. And there's to kind of give it more credit, because, you know, like what you're talking, the stigma, what you're talking about is these people are just whining.
Right. That's
That is the stigma.
And
It
I've
is.
also heard it
And
about,
they
I've
look
also heard
fun.
it about lupus too.
Well, because
You know?
so again, you can have two things, right? So people with lupus maybe have fibromyalgia more
Right.
than people in the average population. So when you see someone with lupus, and there again, it's a huge spectrum. Sick people with lupus are they're big deal patients. Like, we stay up at night worrying about those patients,
those
okay?
patients, for sure.
But you have to, and they've come up with
what
different
are the
terminology.
symptoms of lupus?
Well, so it could be just about anything, but you may have no joint pain. You may have no pain, right? So you have to have 4 organ systems that are, I'm going to say, behaving badly. So the worst one would be your kidneys. So inflammation of your kidneys, you got protein and blood in the urine. You would not know this. You would not feel this, right?
Right.
But that would be one organ that's damaged. Pericarditis, fluid around the heart, chest pain, inflammation of the lungs, rashes is really pretty prevalent. Most people have some type of
Yes.
rash with lupus,
Okay.
whether it's just photosensitivity or what we call subacute cutaneous lupus, which is almost like a horrible sunburn kind of rash. It can look like psoriasis sometimes. And then there's like discoid lupus, which that's scarring, that's a little different, but there's rashes almost always. Raynaud's usually, but it's not like
Yes.
Raynaud. Like we all get Raynaud's probably sometimes.
And what is
Is that the cold?
That's the cold.
The fingers, they
tips.
turn
yes.
white. The fingers
Yeah.
turn white, then they turn blue, and then they revascularize and they turn red when they're getting blood back. But you can get like ulcers on the fingers and they taper. So it's more than just like, I mean, these are people that like they can't go down the refrigerated section of the grocery store without gloves on. Like can be, and sometimes there's
It's
blue.
painful.
Like right
Yeah,
now,
it
they
could
could be
be.
sitting here and they've got blue
that's so
fingers.
horrible.
So they usually have Raynaud's, but you don't have to, right? You don't have to have any of this exact order. So, but that's would be an example. So people just kind of feel bad. I don't know how else to put it. You just don't feel good.
Yeah.
And then and if you don't have joint pain, you never get sent to the rheumatologist.
Oh
right?
my
Because no
gosh.
one thinks
Yeah,
of it.
nobody
Because
thinks of
people
it.
really think of
That's-
rheumatology as joint pain.
So then they don't get diagnosed
right
for
away.
it yet.
Right. It isn't until they're pretty sick or they've gotten their kidneys gotten bad enough that they've now got a lot of swelling or the rash is terrible. Like if the rash is terrible and you get sent to the dermatologist will go, "Oh, I think you might have
Yeah.
lupus." You know, they might then
Make
get
the
there that way.
connection.
Together.
Yeah.
I get a lot of referrals from dermatology.
Yeah.
We share a lot of patients. But in any case, so lupus could be a million things. But it can also be, we used to call it Minnesota lupus, where I trained. You know, it's like an ANA with a rash and some Raynaud's. And that's
Wow,
it. And
and
you're
that's it.
tired. Like, it's not really,
Yeah.
to me, I'm like, that's not really like lupus. But it's more of that fibromyalgia stuff with a little bit of autoimmune abnormalities that you're
Sure.
like, I don't want to dismiss these things, but the symptoms that are limiting their quality of life are the fibromyalgia symptoms, right?
So-
and then you just have to make sure that you're not giving people drugs for some, because
For
you won't
something
get
that they
better.
don't, right.
You're fatigued, all that yucky stuff,
Yeah.
which you totally have, unfortunately will not get better if I give you drugs that slow down your immune system.
How many medications do you think a lupus patient takes?
Well, it depends. It could just be one. They could just be on Plaquenil or hydroxychloroquine because that's like kind of like our aspirin for heart disease. We give that to lupus patients. They might just take that. If you get internal organ system involvement, then we're adding on, immunosuppressive drugs, Cellcept, azathioprine, like drugs you give people to not reject their organs if they get a transplant, that kind of stuff. Now, if we have newer drugs, so we might have to put on a biologic that slows down your B cells. I mean, so there's a lot of different.
You're almost like a private detective as a doctor.
We are good
Yes.
diagnosticians. Rheumatologists, that is like, so like when you, in your day, I'm sure there's something you do that after you do it, you're like, oh, that gave you
Yeah.
energy.
Yes.
Right? As opposed to
Dopamine hit.
you go
Yes.
into
Yeah.
a room
Figured
and you
it out.
leave the room and you're like, I have all my energy left. It's like,
yeah.
sometimes you go in a room and like what gets me excited is when I'm like, oh, I know the answer. I know the answer.
And this is how she's always been. This was her in high school too. Like you're a lifelong learner.
Ooh, I'm gonna make it better.
You
and
love
it's
to figure it out.
fun to make people better.
Yeah.
We don't
Oh, yes.
always, I mean, obviously there are people that, and particularly like these, like chronic pain syndromes, which are. We're just not good at making that better. And obviously, you wait 3 months to come see me. Someone checks some lab that is not related to your problem. Like, people just check a lot of labs because they're trying to help somebody. We get an abnormal lab test, and I'm like, yeah, this has nothing to do with how you feel. I'm really sorry.
I'm sorry.
But, and they're like, this is finally the answer. I've been suffering for 10 years. Now they're going to tell me, and they read about lupus. If you read it, we all have it, right? It's like reading about hypothyroid,
Yeah.
right?
Yeah,
You
don't
read it, and we're
Google
like,
it.
well, I got hypothyroid.
Right.
Like, it's easy to say, okay, yeah, this fits because you're tired and you hurt and you have a rash. I mean, it's easy to go, yeah, this is me. So then you have to kind of unravel that. But so certainly people are disappointed. But when we are treating, when we know what we're treating, we have good therapies, and we usually, most of the time can really make meaningful changes.
How has the advent of these new medications, especially the ones that boost your own immune system and some of those biologics, can you talk a little bit about that? Because that's kind of it's just a wave that's happening with these biologics with treatment of a lot of things. But how's that impacted
So there's
you?
two things. So I use tons of biologics, right? That is like my wheelhouse.
Can you explain what a biologic is?
Exactly. So biologic means it's an antibody. So we've engineered an antibody to bind to something or block something, some enzyme or chemical signal that we have identified as part of the mechanism or the pathology for why you have your disease. So for rheumatoid arthritis, for example, tumor necrosis factor would be this chemical signal. You can't eat or swallow an antibody, so we have to get injections. So it's a shot or an infusion. And so you inject these antibodies, they block this signal, they treat your symptoms. So that is a biologic. Now, the things that make your immune system work more are not what we give, right? We're slowing down the immune system. We don't want to activate your immune system.
Right.
But
Because it loves to activate on everything.
yeah, that's the whole point.
Like
It's
Tina.
overactive.
Yeah.
So we're trying to kind of dampen that overactive immune response and hit these certain targets. So cancer therapy has the drugs that give you they basically give you meds that tell your body to go get that cancer, right? So they stimulate your immune system, which then makes you sometimes, if you have a predilection, develop rheumatoid, develop all of my diseases while you're on your cancer therapy. So we have to now manage. That's a whole new area of patients, right? Because cancer is kind of a chronic disease anymore. We were getting so good at it, which is great. But now we have these prolonged side effects. How do we manage these patients? So we can develop rheumatoid while you're on your cancer therapy because we've activated your immune system to attack your cancer.
My gosh.
And then the third thing is we have something called, which we do this for cancer, it's like CAR T therapy. So it's these chimeric autoantibody receptors, I'm saying that wrong, but to T cells. So we take your T cells out, we then engineer them with a certain receptor that's going to attack something we know for you. So for me, it would be CD19 cells. And then we grow them, we multiply them, and then we give them back to you. Wow. And it's like a very deep suppression of B cells, which is a type of cell that tends to be a problem in my diseases. We give an IV medicine, a biologic that does that, but not as deeply, right? And that can put some people in profound remission. That's experimental, like for lupus. We have not, that is not like, you have to be in a study, and this is like getting a bone marrow transplant. You have to go to a center, you have to stay there for 3 months because, so it's not like you're going to go to Monument Health and get this done.
My mom has Crohn's as well, but then on top of that, she has Parkinson's and multiple myeloma. So CAR T therapy for multiple myeloma patients is a very common thing. And I kind of geek out because I do read the studies on new medications and treatments for Parkinson's and multiple myeloma. So when you said that, that really resonates with.
Yeah, and so it's not like, prime time for rheumatology, and I don't know, even in my lifetime as a rheumatologist, if I will, how much, but I mean, it's there. For some of our diseases, I mean, I would say for most people with lupus, we can manage with medicine. They live a good quality of life and we can control their symptoms very well. This is for that, person that we throw everything at them and they're going to get, their kidneys are going to fail. Like they are, and they're 25, right? I mean, these is like, you're going to have to get, have to get a transplant. And, and it's just, it's a whole thing.
A hard life.
And you can go, I mean, it puts people in remission. They take no medicine afterwards, the ones that have been successful. So it's really fascinating, but I think it's just kind of the future. It's super expensive unless we can make it cheaper, do it faster.
Sure.
They've talked about like kind of almost like these, there's a bunch of different ways in which people are investigating how to do this better. I think it'll go.
How do your genetics play into these diseases?
I think it's really complicated. I mean, there are some genetic risks, but I would say that's not the biggest player. I think it's, like we say with the standard approach or answer I would give is you maybe have some genetic risk, right, built in. You have some environmental exposure. It could be anything. I don't know what. It could be, let's blame processed food.
Yeah.
We blame
you
that
grew
for
up
everything.
on a farm, whatever.
You stirred the chemicals.
Yeah, exactly.
I mean, that's like Parkinson's.
That is another
100%
conversation.
Parkinson's would be that. So, but that, and then, and it's kind of like a perfect storm. It's like the right time, the right combination of things happen. And once that cat gets out of the bag, that's the challenge. People will say, well, I had a bee sting and then I got my joint swelling a week later. I'm sure the bee sting caused it. And I'm like, well, I don't know. It may have nothing to do with each other, but in our minds it does. I go, but it doesn't really matter because now you have it, and now we just have to deal with it. I can't undo it.
You can't undo it.
No.
And I think the hard thing with like me, well, maybe you heard this, maybe you didn't, but when Tina got septic after her surgery, I was describing to, I think I was talking to Alicia, our dermatologist, and I said, listen, Tina is like an exotic orchid that only exists in the deep corners of the Amazon in specific light and humidity conditions. And I have this fucking orchid in South Dakota that I'm trying to keep alive over here who reacts to everything differently than the normal human would. And so, like her disease management or her, when she was sick, it was a lot of like, okay, wait, hold on, like, and she had this allergic reaction to a strong antibiotic, but I could have said before that when I was like, you better dose her with some Benadryl because, I mean, this is her. Like, she just is very reactive to certain
very
things,
sensitive.
and
I
we have
think
to
this
be
is
really
that
careful.
N of one, right?
Yeah.
You have to learn your patient.
Yeah.
And everyone's different. And I'll say, like, I'll meet you, you transfer your care to me. I'm like, I usually don't change much out of the gate because I'm like, I haven't known
I need
you
to
yet.
know you.
I don't. I got to figure out, are you? And there are those people.
Yeah.
That just nothing. Everything bothers them. I don't know why. Like, everything has like the whatever weird side effect. That's the 15 things down that somebody reported. They get it. I don't know.
Yeah.
There are those people.
All of the people on the
1%er.
bottom of the
Yeah.
commercials.
There are
that-
those people, and what do? You know,
Yeah.
it's just it is what it is, and you just have to kind of work through that. But that's the challenge. That's the challenge.
I'm curious too. You know, we talked about kind of the wave of the future with CAR T, and have you, shifting gears a little bit back to RA, do you feel like, or have you seen any impact on RA with GLP-1s?
No.
That's a good question.
So what I would say, there definitely has. There's been some people report their RA symptoms are better on GLP-1s, which I think personally reflects improved metabolic health.
There you go.
Right?
Okay.
If your metabolic health is better, you feel better.
joint, yeah.
So when you get that corrected, just your overall, it's like if you're in autoimmune state, your immune system is not well controlled. We dampen that. A lot of people will say, I actually feel better. I thought I was going to get sick all the time because you're giving me these drugs,
Right.
and I actually feel better. And I think that's what we see.
Sure.
Now, obviously, if you have degenerative arthritis and people get knee pain, losing weight, that is 100%. Helps.
Yeah.
Right? That symptom.
Yeah.
So that'll help those symptoms if you have knee pain, which you can obviously have rheumatoid and osteo and all these things together, right? For psoriasis in particular, so people with psoriatic arthritis, so they have the skin psoriasis, itchy, flaky, nasty rash, and they get these inflamed joints. Losing weight helps with the skin, and it seems to help with the joints. And so there's really a push to give people who it's appropriate these medicines. So I've seen people feel better after they lost a lot of weight.
So an
period.
indirect
Not
correlation.
I didn't prescribe it.
Sure.
But in terms of, I've only prescribed it once so far, mostly to see how hard it was to get it approved. Because of course, this is my day.
Yes.
Is basically,
Yes.
I have so many drugs that I have to work on. Like the idea that I have to now authorize another medication is kind of like, no, I don't want to do it. But I do think that I'm going to end up having to prescribe these medications for people because I do think it will help them in other ways.
Yes.
Right? Yeah. And I don't think they're not like right now they're the it drug but they're not a cure all by any stretch. And there are certain people who don't lose any weight on them and don't tolerate them and whatever. But I think when you have some success, it's easier to make those good choices. You're motivated.
Yeah.
Right.
Well, as opposed to when you try really, really
You're
hard to lose weight
invested
and
in
you
your
never
health.
get any success
Yeah.
and you're like, why do I bother?
Why do
I
I
might as
bother?
well have that cupcake. I never lose weight anyway, and I'm
Right.
just suffering and not getting any results. You at least start to get some results, and that motivates people, and then people like how they feel, and it kind of feeds that.
Yeah.
So I personally, we'll see what it. Right now it's really just people reporting their symptoms are better. But is it really their symptoms from RA, or is it from being overweight and metabolically
all the other
unhealthy?
things, so an indirect.
Yeah. So I'm not sure. Like, I don't think it's changing the mechanism of RA. I don't think it's going to be like, oh, I'm going to start you on your RA med and then add this in the third month because it's going to make. Yeah, I don't know that's
you're
where it
there.
is, but
Okay.
but it's definitely for some people going to complement things.
Yeah,
but it's just hard to
interesting.
get
I'm
it.
just
It's a
curious.
pain.
It is hard to get.
Yes,
isn't
it's
it?
a pain.
Yeah.
I mean, you have to be persistent. This gets back to chronic disease, collaborating, communicating. So if you are in a clinic, you're a primary care person, and you have to see your 20 odd people today, and you have so much going on, you don't maybe have time in your workflow to be directed to getting this drug approved, right? In a chronic disease clinic, this is what we do all day, and so we're constantly like, we have all these touches after your visit,
Yeah.
right?
Yeah.
And that's part of our workflow. So we do it better because we have that workflow
You
in
have
there.
that.
But it's sort of like, how much more can we
Take on.
That's
Yeah.
so this is
Yeah.
where it's kind of like, we need to just change our name. do we just take care of the complicated stuff?
You're
And
tired, you're
and then-
poor.
yeah, because it's just challenging, and I get why other people we take care of people from a wide range, like
Geographic area too.
Dickinson,
Yeah.
Casper, Nebraska, and they have nurse practitioners and PAs in these little towns, and they're like, yeah, I can't do that. That's too, I'm not going to do that. I'm like, how am I going to work with a primer that can't even address this issue, right? So then we have to take it on.
Then you take it on.
You get all the leftover stuff
So-
people
Little
can't
bit.
figure
I want to
out.
ask
huh?
a question.
Well, or whatever. It is what it is, but it's going to evolve. I think
Yeah.
for sure we'll end up prescribing them more often.
I'm
Sorry, I didn't mean to interrupt.
no. I think that you. I do feel that as well, just from things that
Yeah.
I've read about my own situation, my mom's, health journey. I just hope that it is they make it easier for people
Yeah.
to
For
get
sure.
it.
Well, I think the challenge in general in America is when people aren't getting what they want, unfortunately, I should say unfortunately, but you can go anywhere and get something.
Yeah.
And it's maybe not good.
Right.
Right.
And when people are going, like if people are frustrated, like, oh, I wish people wouldn't go do X, Y, or Z at that, pop-up clinic down the street that's,
Right.
it's because they're not getting what they want
Yeah.
they're not getting what they need
Yeah.
from us.
No, the pop-up
Right?
clinic that advertises, hormone replacement therapy,
Everything,
and it's
yeah.
really just a B12 injection.
Yeah, that, or
Yeah.
we can do your Botox, and then we'll give you your estrogen, and then, whatever it is. But I'm
Right.
just saying, like,
Yeah.
it's because we're not doing that. If we were doing that well, they wouldn't go somewhere else and
Right.
look for it.
Right.
So why can't we do that better? And that's, I think, just part of the.
I kind of want to
Healthcare
flip the
system.
question though, which is, we're here and you're talking about all the ways that you're an amazing doctor.
Oh, no,
and you
no.
are. No,
You
it's
are.
very
Yes,
Don't
true.
you
are.
deny it.
Yes, you are.
But I want to ask you, how do people be a good patient? Like, what's a good patient
question.
for you?
Ooh, I like
Because
that.
this goes back to my customer service. People say, "What happened to customer service?" And I say, "What happened to customer behavior?"
Yeah.
And so
Sure,
I
for
want
sure.
like what's your avatar patient look like?
Somebody who doesn't Google it first.
Well, I guess it's a tough question because so my perfect patient, you're saying, would be.
Like, how do patients meet you and help you help them?
I mean, it's a tough question because I would say I usually have to kind of figure out, like, you can kind of tell a little bit. You have to find out where they're at, right? And what are they willing to do? Like, because there are some people you can kind of tell are going to be resistant to what you're telling them to do. And then there's other people that are like, you're the doctor, tell me what to do. Like, that's probably the easiest patient, right? The person's like, you know what you're doing.
Just tell me what
Tell
to
me
do.
what to
and
do.
I'll do it.
I'll do it.
Yeah.
I'll show up. They don't. They're not maybe driving my nurse crazy with a lot of messages.
Questioning and-
With like every little thing. But and I always tell my nurses when there's someone messaging a lot and they're getting like frustrated, I'll be like, they're just scared. 9 times out of 10, it's anxiety and fear. And once we get that, once they realize like we have this handled. Like, we are here, then it'll slow
it
down.
comes down.
It'll slow
Yeah.
down. So
Yeah.
it's usually a temporary thing, but I would say someone who is willing to take our advice. And again, if you're coming to see me, I'm a medical doctor. I do prescribe medication. I follow the American College of Rheumatology guidelines. I'm not going to like chant over you, right? Like, if you come to me and go, I don't want to take any medicine.
That was my next question.
And I don't want to do any of that. And I want you to sort of, and I've done this. I mean, I've done this because I want to please people. We are people pleasers. You think, oh, I'll be supportive, and eventually they'll change their mind. But I want to do this other thing,
Holistic
And I want you as a
yeah.
placeholder when things don't go well, and you think, well, eventually. I kind of said, you know what? If you're not into what I do, which is fine, then come back when you're ready to do that. Because I've learned that people don't generally change their mind. I am not a mind changer. I'm not I don't get you from I don't trust healthcare to, it just doesn't, it
Yeah,
doesn't work.
that's
You
a
have to
big leap.
wait
Yeah,
for them to
that's-
either be ready to try that.
Yeah.
And sometimes I feel like when I haven't done that, when I've tried to be like, I'll see you every year, every 6 months, I'll be supportive, I'll keep trying to encourage you to try X, Y, or Z, that in essence I'm validating them not doing anything is how
Right.
I've learned.
That's
and they don't
true.
they don't get better, and then now they're a hot mess 10 years later with medical
progressed-
problems
with
a
because of
progressed
this
disease,
and
yeah.
you're like and you're like, okay, I don't think I really did them a service. I thought I was doing them a service by being supportive, but I really didn't. I should have just...
You supported their inaction is what you
Yes,
right.
yes,
Yeah.
yes.
This can't be healed with essential oils.
So I would say, you know, a patient that's obviously open to what I have to offer, right? If they made an appointment with me, that the kind of stuff I do is something they're going to be willing to consider. And then I think just, you know, you have to be a little bit patient. I think sometimes expectations, like,
and people
treating
need
it
time
like
to
I
process.
don't sell shoes.
Right.
Like I
Right.
don't, like it's not like if you don't like this, you know, calling me back upset because it's been 3 weeks and you're not better, and kind of that, this is unacceptable. Whenever people tell me that, like, it's unacceptable. I'm like, well, it's not like I saved better medicine aside, and you know, like I'm always trying to give you what
my best.
I'm giving you my best advice. I would not tell you to take it if I thought it was dangerous or bad for you. Like, you know, I mean, I'm balancing that in my head. I'm trying to do the best for you. So I suppose when you get that kind of feedback, that kind of mean, but it's not very often. And I always say, like, I'm like, love the one you're with, right? I feel like life isn't patients. There's a niche of patients, and you always will have, you know, a super anxious patient. You have the patients who are way too tolerant, where you're like, if they call, bring them in, like. That person
You know
never
it's
complains.
bad.
Oh my God,
complains.
this is like that person. We jump when because that's not their nature. And another one might, you know, call all the time. You know, we just have to be reassuring. You got these broad spectrum, but it's like you'll have a patient that might be really challenging. And what I've learned is, like, right away you'll think, oh, this is gonna be really hard. This is gonna be really hard. And then you learn. If they stay, if they come back, right? Because I'm like, if you don't like me, you just won't come back. That's okay.
Right.
You don't have to like me.
Right.
But if you come back and we work through that and we kind of learn each other, we eventually get along. Like, it's okay. And it's kind of like love the one you're with. Because if they leave or move, I get another person in that niche that I got to learn.
Yeah.
And
true.
I find I feel like there's only a handful of those people at all times. So I'm always just like, nurture the ones we have. then we won't have another. It's like you eventually get past it. I remember my one old medical assistant said, she goes, you know, sometimes there's a person that I'm thinking, oh, this is going to be a really difficult patient. She goes, I just love them now. And I'm like, that's true. You
it's so
eventually
That's me too.
like work through
adjust.
it, and if we're gonna be friends, if we're gonna work together, we eventually, you know, you accept what you don't like about me or whatever, you know, whatever I'm doing,
you
and then
find
and
this
I have to.
common ground.
This is our goals, and we've agreed on these goals, and we're gonna keep moving forward and be respectful, and you try to do that. But it can be challenging. I mean, but it's just so different. I mean, there's no perfect patient really. There's probably just easier, which isn't always better, right? Someone who never complains comes in, says, "Oh, I'm fine, and then goes home and complains to Jenny about how awful they're doing or something. Like, that's kind of what some patients do, and then the loved one calls and
I'm
says,
the problem. It's me.
like, what's going on, or you know, I mean, you get a different story. So I mean, that might be easy because they aren't complaining, and so you're like, okay, great, treatment's going well, off you go. Versus someone who's really doing well but has a lot of anxiety, might take a lot of time.
And I think with the diseases that you manage, they're complicated they're multi-system, like you said. And for somebody going through that already doesn't feel good, to try to have to understand and learn about the condition that they have difficult. Can be really overwhelming.
Well, I mean, keep in mind, so I feel like everybody who sees me tells everyone else they have RA. That's just what they say. Like, if they go to the ER, my husband's emergency medicine, and I guarantee you, and he probably, like, if someone comes into his ER and says, yeah, I have RA, he goes, okay. He's not going to go, do you really? Let me examine your joints and double check. Because you're there for, like, chest pain. It's like, I'm here to make sure you don't have a heart attack. You know, he's not going to, but he's going to write it down like everybody will do. And now it says you have RA.
I've never
and
thought
I'll be
about
like,
that.
you don't have RA. They never had RA. They have, you know, something else, gout. I don't know. You know what I mean? It could be anything. And so it's just people, you know, that I've taken care of. And I feel like I talk a lot, clearly. And I feel like we've shared information. And it'll be like a year. And they'll go, so what do I have? And I'll be like,
a year?
Yeah, years. And I print out their summary after every visit, has every diagnosis and what to do on it. And they'll be like, don't I have RA? I'm like, no.
You've never had RA.
You know, or you're like, don't I have, like, I've got, and I'm like, no, because people really perceive if they have hand pain, they have rheumatoid.
Right.
That is, and if they have any of those osteoarthritic bumps, you know, the bumps you have on your digits that you get as you get older?
one.
Okay, yes, exactly.
This one right here.
And they'll say, well, I have a nodule, because I think it's rheumatoid nodule. And so people just, that's just sort of, that's an easy association. It makes sense to them. And so I'll sit there and think, oh, we're doing such a good job educating. And then they'll be like, oh, I didn't know I had that. And you're like, oh my gosh. So my mom, the English teacher, used to say it takes 7 times to hear something before you get it. And it might even, and if you're, or more, right?
Right.
So sometimes you just have to kind of reiterate and reiterate and reiterate. But some people are going to be really, they've Googled it, they've read it, they're on the Facebook groups. They're doing all of it, and they know exactly what they have, and they're calling for the latest, greatest treatment. And there's other people who they never do that. That is not part of they're like, as long as I don't feel bad, I just take the thing that you told me. My wife fills the things. I don't even know what I take. I mean, there's a whole range of health awareness and I would say risk level comfort.
Yeah.
Sure.
Like, I'll she told me take it, I take it.
Yeah.
There's a lot of people who like, no way. I'm Googling it. And then of course we have the 3rd degree cousin opinion.
Right.
For
yes.
everything.
Yes.
Oh, yeah.
I came in. I know
too.
I saw you. You gave me a great explanation for what happened. But my cousin's brother's uncle's 3rd cousin told me, right?
At a family reunion.
Because
2 years
everybody
ago.
has a story of someone with a weird disease that took forever to be diagnosed and ended up being this other thing. I mean,
right.
everyone has these stories,
So
and
I
they're
have
real.
I have
ever-
a funny story. So I called my mom a few weeks ago, and there's like noise in the background, and I'm like, where are you? And she said, well, I'm down here at this place, and she's describing the strip mall over here, and I'm with your dad, and we're getting some testosterone shots. I go, why would dad, my elderly dad, why would dad need testosterone shots? Well, they live in a retirement community. Jennifer's parents live in the same retirement community. My mother still refers to it as Shady Pines because, out to pasture, which is funny. But she said, I heard in the dining room that testosterone shots will help your dad's balance. And I said, okay. And so I actually had an appointment with my hormone person. And so I called my dad and I said, hey, why don't you come to this appointment with me? Just ride along. Let's just ask her. So we go to the appointment. We're in with the provider who I've, messaged ahead of time. I didn't just spring a stranger on my provider. And I just said in front of my dad, I asked these questions about the testosterone, and she said, that's not
real
treatment. That's not a thing.
Oh my goodness.
And I tell my dad hears all of this. I call my mom and I say, actually, these testosterone shots can thicken his blood. And there's some risk factors associated with testosterone injections in somebody like dad who had a stroke. Blood viscosity is a thing. So she calls me a week later and she said, well, we're going to keep doing them because they're helping. And so my dad is literally sitting at the Body Shop, which is a bodybuilder weightlifting store where you buy all your supplements. And my little elderly dad is sitting in the waiting room with all these muscle heads waiting to get his testosterone injection. And I just have to go, okay. I'm like, well, I don't agree. I think this is not a great idea.
This is not smart, but
okay.
they're going to do what
Is it
they-
helping him or your mom?
We don't want to know.
I don't think
There's no answer to that question.
Yes.
Okay.
That's right.
I have another question for you, which is if you could change anything about our current medical system or how it works, how would it be? And there can be more than one answer.
Right now, our current healthcare system is like a fee-for-service. So you get paid only when I'm sitting in front of you. Mm-hmm. We don't get paid for anything else. So you can only, that's why we have these 15, 20 minutes. We have to cram all these people in because we have to pay for all the other stuff, right? Mm-hmm. So, I would and they've been trying to do this. It's just not been successful, but paying on quality. What's quality? But I feel like, I think we're going to see capitated payments. Medicare's just going to give you X amount of dollars, and then you all got to share it.
Yeah.
And I think but that's the drive right now is you just have to see more people to cover your costs. The reimbursements have gone down, costs of everything else have gone up. So people are kind of pinched. So it's just like, and there's a sweet spot of I can see this many people and not make mistakes, but you start to see more people and you forgot to send in the prescription or you forgot to send the referral or little things happen, right? You miss something in documentation, you got to go back and write an addendum, little things. So there's a sweet spot of that, and I think we're pushing that where everyone's having to do more with less. So I, would want a system that allows you to see a reasonable number of people a day and have the time that people need for this. 20 minutes, it's hard to tell somebody go through 3 chronic diseases, which is typically what we would do. Is like you have rheumatoid arthritis, you have osteoporosis because I've given you steroids and I've got to manage that, and maybe you have, degenerative arthritis, like a bad knee,
right.
And we're managing all those, your anti-inflammatory and your osteoporosis medication and your biologic for your rheumatoid, and and then your husband died. And so we got to talk about that because that's stressful and you're not sleeping. And all of this bleeds together, right?
Right.
That is hard to do in 20 minutes, right? So you run late and everybody, all of this. Yep. So I think if we could just, if I could have longer visits and see less people and be compensated fairly for that, that would be an improvement, but that would just be changing the way we pay. And I guess in my world as a rheumatologist, if we did a capitated thing that says, okay, you'll get this much of the pie, probably I'll get very little of that pie, right? That's the reality. So it's probably not a good deal for me.
To primaries and
and
like that,
surgery, and whatever, and hospital. I mean, I would say primary
risk,
care and rheumatology. Although we're a subspecialist, we don't get paid any different than primary care. I mean, it's the same E&M service. Yeah, nothing different. So we can see less people because they're more complicated, but we can't really. We don't get paid more to do that. So. It's just that would probably be the thing. It'd be nice. My day, what I don't like about my day, I love my job, but what's hard for me my day is I get up at 5:30, I prep my charts. So I have to look through my charts, make sure they're, because you have to kind of get your brain around the person before you go in.
Yeah, totally.
So you have to get that all prepped. And then I get ready, I go to work. I work through lunch. So over lunch, I don't eat. Generally, I have a few nuts or something. And I close my notes from the morning if I can. I respond to all the phone calls that came in for the morning that I can. I close out any labs that have popped in, right? And then I do my afternoon. And then as soon as I finish my last patient, I go to my phone calls to send it to my nurse so she can respond and get back to these people, right? And then if all that's done and they're good, my nursing staff can leave, then I stay till 6 and I finish up as much work as I can, which may not be everything, right? Maybe it's a bad day, but maybe I got everything done. Maybe it's 5:45, I'm walking out and I'm like, great. Maybe it's 6 and I've got stuff to do. But that's your day. It's you don't do anything else. You don't text somebody. You don't look on TikTok. You don't read the news. You don't hear from your kids. You just work
do the thing
all day.
Yeah.
We don't ever talk during the day. And I told Tina and I tell my staff too. I said, when I come here, I feel like I'm getting on a carnival ride, and I don't know when the carnival ride is going to end, or when I'm going to get off. But I'm just in. I'm on for the ride, and that's every day with clients and appointments and blah blah blah.
Because we both, we're head down, nose forward, just like you. It's a 12, 13, 14-hour day, and
that's fine. But it's just it'd be nice to not feel so there's a sense of pressure.
Yeah.
Because you don't want to be late and you want to be respectful of people's time, but then this person's got more issues, and so you're trying to get a lot done and cram it in. You'd like to have more time. And I think everybody would like to have more time.
Just to take a breath.
Right? And just be able to say, okay, I'm going to take a 10-minute walk at lunch, or I'm going to actually be able to go have, my husband and I would
eat something.
So Steve works weird hours. So sometimes, this is a few years ago, our kids are in school and we'd go have lunch. That would be our.
What does your husband do?
He's emergency medicine.
So
we'd go out at lunch and we'd see people eating.
And
we're
weird.
and they're working, and they're
weird.
working people, and we're
what is that?
People do this every day. They go out and have lunch. I go, this is fascinating. I want one of those jobs where I can go exercise over the noon hour and then come back to my afternoon. I mean, can you imagine?
No, I can't.
It'd be so amazing.
I had a meeting at the golf course actually, and it happened to be men's day.
Yeah.
It was Wednesday, and I looked out the window of the dining room, and there's all these professional men that I know who are, and I'm like, they're golfing for 3 hours on a Wednesday. Like, it was diabolical to me.
Yes, they finish their day early. They get there by 2. They prioritize it.
Yes,
they
they do.
prioritize it, and that's so. I realize that I do this to myself. Like, no one said, Jennifer, you can't eat lunch and you have to get, like, no one said that.
I know.
But, like, that's whatever I've evolved into
thinking
this.
You're doing what you have to do.
I've evolved into this, and I'm
We're
like,
Gen X. We're very responsible.
I
We're
don't
very
know.
responsible.
But so that would be my thing. I think if we could have more time with patients, and then I think just, how would I say, like, we are too compartmalized. Right?
Everybody's pretty siloed.
So subspecialized, and everybody's like, well, to my primary care colleagues who I respect tremendously, they get dumped on. Everyone's like, well, the primary should do that.
1,000
And I'm
times.
like, who has time to do all of this? Like, so everybody just, like, I always like, if you go to a national meeting, like if I go to the American College of Rheumatology meeting, and I trained at Mayo for fellowship, and you talk to all those people, and you're at a tertiary center, that's like your place you go to when you can't figure things out. And the people that have all the guidelines, they have all the time, and they just see people for consults, and they see, like, I don't know, maybe 12 people a day.
But they're academics.
Yeah, they're academics. And they're like, okay, when you see this person, you should do labs, every 8.5 day. And, and you're something that you're like, that is not practical or real. We are never going to be able.
I'm trying to keep an orchid alive in South
yes,
Dakota.
Yeah, this is not like my patients drive 4 hours. They're not gonna. They're just not gonna do these things, right? So it's this disconnect from the science of things, and they'll say, like, they'll see you and go, okay, go back home and have them take care of this. And you're like,
They live
there's
in Bison.
nobody back home that's going to take care of this.
No.
Just even really simple things. They're just not comfortable doing it. And so then it falls, like I said, kind of to someone like me, which, again, we're good at that. We're good at chronic disease. We're good at getting meds. We're comfortable with sick people. We're comfortable with, you can be really sick. It doesn't freak us out too much. But we're not really, the system isn't built for us to take on all these people in this way. And so I jokingly have said to my PA, who's fantastic and has been with me for many years, and she's wonderful, I told her we could just open up a chronic disease clinic and just do it the way we want to do it. Of course, I don't know how we get paid. Right, that's the reality. But I'm like, this is what we really do, is just organize a lot of data, make sure you get all your meds, communicate with other people. This is really, because everything we do just bleeds into everybody else's stuff.
It does.
So it's challenging.
Yeah.
But yeah, I don't know. It's definitely broken. 100% broken.
Well, and I think what I see on the advocacy side, because I manage a lot of complex patients who have, so many specialties, and they're seeing providers across different healthcare networks that don't talk to each other, right? And so when I have those patients, especially patients like orchids, like Tina, where it's very important to piece together that communication, because if somebody comes to see you at your company, right, but they've seen a primary care at a different system and been prescribed meds, and maybe then they had like a referral somewhere, an outside referral somewhere else, where somebody else is in the mix. And a lot of times I get into these cases and nobody knows what anybody else is doing. And so it's really like the collaboration is huge, because then it's my job to say, okay, who are all the people and how do I close the gap on making sure that everybody is looking at all of the right information and that they all know who each other are, because sometimes they don't even know who those other providers are. And I think I just am so disappointed that in 2025, we are talking about literally computer systems and charting systems that
don't communicate
with each other.
One EMR would be helpful.
Yeah.
I don't disagree with that. That would be huge, because people don't look.
Right.
Because, again, we're on this time crunch, so people don't go look for the record. Like, if I fax, so I'm not part of Epic. So if my patient's at Epic, I fax my note, it gets put in this media section. And People just don't. They
They
don't
don't
look.
know.
look in that.
I,
They don't look.
I say
They
10
could.
times
They
a
just
day.
choose not to.
I say, can you look in media?
Yeah.
I say it a lot.
It's really true.
true.
And so now it's getting better. I will say that is improving because there's care everywhere with Epic. And even on our EMR, we can see some things from Sanford. And so it's getting a little better. But I agree in general. So I'm old, right? Back in the day when I first started practicing, people sent referral letters. Because they weren't on electronic chart. And they'd say, please see this person. I did this test. I did that test. I don't know what's going on. And there was definitely I don't want to send someone until I've done my job or you'll think I'm stupid. Right? That was kind of the mantra. EMRs have made it so, like, you come out of a room and they say, send a referral
just
to
bounce
rheumatology.
pass.
And the nurse types, please eval, and sends, and you're like, we get like 50 pages in a referral, and we're supposed to figure out what it is we're supposed to see him for. And so my nurse will go, I don't even know what I'm supposed to be pulling out of here, Dr. May. And so then I'll say, well, try to get more records, and it delays all that. And then you'll say, okay, fine, just see them, because I don't even know. Like, it's just easier to see them at this point. We're confused.
sort it
And then
out.
we see the person, and they're like miserable, and you feel bad that you delayed the referral, but you're like, and they're kind of upset, right? It took me 3 months to see you. This is unacceptable. And you'll go, okay, but your person didn't communicate anything to me that let me know you were suffering, right? To triage, we do the best we can, but it is unrealistic to expect me to breeze through 75 pages of material to imagine what you were thinking.
Yeah.
And that is the reality of referrals. So they used to be some thought to them. Now it is really just like this, eval and treat. And we have to dig out what we're supposed to do. And that delays things 100%.
It's like it used to be a relay where you passed a baton to an actual teammate. And now it's just a bounce pass and you're on to the next thing.
And so for me as a consultant, what I would say is if I'm seeing someone, if you ask to, the way I was trained is, I have a question. Will you please answer my question? So for a rheumatologist, a common thing would be, you came in with joint pain. I ordered a bunch of tests. One of the tests is abnormal. I don't know what to do with it. Go see the rheumatologist. That's a slam dunk rheumatology consult. I can read this and tell you, I don't think this test means anything, but I have to see you and make, because it's different when you see the person, right? I might change my mind after I meet you. So to me, the question is this blood test clinically meaningful? That's what I think the referral is. The patient is, I've been hurting for 25 years. You're going to fix me. Right? Really?
Yes,
I mean,
you're
they're like, well, I don't care about that blood test. You're supposed to make me not hurt anymore. Like,
I don't wanna hurt
there's
anymore.
a disconnect, right? But then my idea is, I've answered your question. I'm going to send that back to you, and you're going to see the patient and go, okay, so that's not it. So now what do we do? Many times they have no follow-up appointment. And they're never going to go back and see that person. Like when I say, well you're going to go back to person X, they'll be like, nah, I don't know. I didn't like that. I don't think I'm going to go back there. So they have no follow-up. And now I've also probably diagnosed them with diabetes or whatever else. And I'm like, well, you really need to get into someone. Well, and then you're trying to find them a primary. I mean, so it is less, own the patient. It's something people say, but it's not very well in these systems. It's just like get them seen. So I think that's a challenge. If it was a real consulting, okay, I have this question. Now I'm going to see you back, but that's not quite. I mean, it's kind of evolved away from that.
So if we did, do you think if we did a better job of, triaging people based on level of acuity, and you got a better understanding, would that streamline the appointments that you have? Like, how many appointments are you going into where, you're like,
there's a disconnect.
Yeah.
We've talked about this because you could say, I think this referral is. Are we running out of time?
No.
Yeah,
but I'm like, is
we
this
actually
referral?
are.
We are.
Oh,
There's
okay.
more.
Well, anyway, I would just say that I think we've talked about doing like telemedicine visits for ones we think are low acuity to see if we can't just kind of quickly address them, weed them out, and so we aren't bogging down the whole system. So we've talked about that.
Yeah. Okay, my last question for you. So, you've done this a long time. We're steaming into middle age.
Yes.
So tell me,
if you say menopause, I'm going to freak out.
No.
I'm like, there's no time for that.
What's one thing, or what's one way that you approach your work today versus like when you think about yourself as a new physician?
Good question.
Well, I'm definitely more confident, right? So when you first start out, I think you're worried about making a lot of mistakes. So I feel like I'm more confident in my like I can go in a room and very quickly I kind of know what's going on.
You know what's up.
Pretty quick.
Yeah.
And I do all the stuff. I have to, I'm making sure I cover all my bases, but I feel like I'm more confident in what I know and in what I can do. And I'm more willing to say, yeah, I'm not doing that.
Yeah.
Like I'm not going to overstretch myself. I had a partner once that I remember thinking, oh, he's just giving up, and it's not that. It's like, this is not really, I don't have the resources to do this for you. We need to send you somewhere else. And I think I would have been like, oh no, dig in. I'll keep trying, which is not wrong, but it's, at some point you have to, like, I think,
What are we doing?
If I'm not helping you, or if I can't, like, I need to get the right people, and I'm just going to do that sooner if I need it. But that's probably the biggest thing. And then, I always said yes, right? I was definitely trained to always do more. The more you do, people will be so grateful. Not true.
No,
Not true. The more you do, the more they take.
The more they take.
So I had to kind of go, you know what, I'm not going to apologize for, I see patients 3 days a week. My PA sees people 3 days a week. And so we overlap on one day and staff and work very closely together. And I think when I first started doing that, it was like, oh, well, you don't work full time, so you're not. But I'm like, I do work full time. I mean, I put in 50. I mean, I'm not complaining. I have a good life as a physician. It could be much worse. I could be a general surgeon or something like that, and all the time. But my point is, that's what it took for me to have balance, so that I'm not burnt out when I come in to see people, and I had time for my family. So that's what I did. Now, as my kids are grown, I'm learning, like, I haven't really had enough time yet to just feel it, but I think I'm going to be like, this is not that bad, right? Because like, if I don't have to run home and make dinner and get to something,
Sure. I'm good.
Yeah.
This is
like,
just
this
me
is
good. Like,
This is
so
good.
when I felt really burnt out sometimes before, even with that schedule, like, oh my God, I cannot do this one more day. I'm like, well, I got to see how it's like when I don't have all this other stuff.
Yeah.
And I think it'll be more doable. But but yeah, that's probably it. Just more comfortable in my own skin, feel comfortable saying, that I'm not good at that, or I don't know that, and not beat myself up over it.
Thank you for caring for people.
Yeah.
Yes, thank you for what you do.
Yes.
I could sit
Yes.
here and listen to you
I
all
know,
day.
me too.
I know it.
We're going to have you back.
Oh, there's
So-
always more to talk about.
Always more.
rheumatology.
Yes.
It's
So
like an
Jennifer
enigma.
May, we will link all of her information in the show notes. If people have questions, they can email us at info@theunicornprojects.com or call 605. No, God, I'm screwing
You're
it up.
okay. You're okay.
844-605-5433.
There we go.
Okay.
Job
Okay.
well done, kids.
Let's
All right.
Thank you for having
unicorn.
me.
Unicorn.
It was fun. Okay, what I do?
We got to do
Yes.
Okay.
Unicorn.
Awesome.
There.
Thank you for tuning in to the Unicorn Projects, hosted by Amy Rose with Jenny and Tina. Music by Caroline Kilty. Produced by Russ Haddon. Engineered by Chris Jaquez. It's the Unicorn Projects on the Home Slice Audio Network.